So, good morning, like everyone said, and please maintain your microphones on mute until the end for the questions. Although I will be grateful if you have any questions during the presentation to go ahead and input them into the chat, right? And I can just scroll through the questions at the end. Also, I would like to thank you, Sayed Kamran from Bengaluru, India, for the invitation. I hope I didn't butcher any pronunciation there. Their audience is 80% from the Southeast Asia, right? That's correct?
Yes, yes.
Okay, so I love their posts. They're in Pharmacy InShort. You can follow them on Instagram. And they're very dynamic. They're very actively daily with posts. And I loved an oncology pharmacy post that they had. So I just went ahead and I shared it. So here I am giving a presentation of an overview, right, of anti-cancer treatments, toxicities, and interactions. It's going to be an overview, right, because it's a lot of content, but bear with me, so I will continue here. And then we can see that we have various topics that we're going to be touching up on. Are chemotherapy and anti-cancer treatments the same? Is the overview of metabolism and side effects, interactions and toxicities, chemotherapy, adjunctive medications, and even a little topic is overlapping of COVID-19 and cancer, okay? So even though today's presentation is very limited, you can see I have various topics online. I will go through them briefly, yet as thoroughly as possible, okay? Once again, for questions, kindly, you can ask me and hold on to them on the chat, okay? So I continue here. Now the question is, are chemotherapy and anti-cancer the same? Well, not entirely. You see, the word chemotherapy is chemo. Well, it's often used when referring to medications or drugs that treat cancer. But not all drugs used to treat cancer work in the same way, right? We have the chemotherapy, right? The drugs that travel through the body. Oh, wait a minute. Okay, so like I was saying, well, the chemotherapy is cytotoxic, right? Meaning that it kills tumors. But in reality, the anti-cancer treatments, they can be surgery, radiation, chemotherapy, right? Within the anti-cancer treatments, we have hormone therapy, biologic therapy, targeted therapy, immunotherapy, or vaccines, right? That we're there, but we're gonna be, that's a little touchy subject. So, and we're also gonna have their factors to consider, right? When we are recommending these treatments. And the factors, they would be the type or subtype of cancer, the stage of the cancer, the results of the test of the tumor, such as biomarkers, the patient's age, the patient's overall health, right, the current medications, or other serious health problems. Now, there are three main goals when we are searching for chemotherapy. We have cure, control, or palliation. For the control, it's possible that chemo is used to cure cancer, meaning that the cancer is destroyed. It goes away and doesn't come back. For the control, if cure is not possible, the goal of the cancer treatment may be to control the disease. In these cases, chemotherapy is used to shrink, right? Shrink the tumor. Maybe it's not operable, and with this treatment, it will be. And this can help the person with cancer feel better and live longer. Palliation, right? It's when the chemo can also be used to ease symptoms caused by the cancer. So this is palliation or palliative chemotherapy. Anyway, here. So through various mechanisms of chemotherapy, right, we have regimens that can be highly toxic. The majority adverse effects are due to damaging or non-cancerous rapid dividing cells in the GI tract, hair follicles, or bone marrow, that this is where the production of blood cells take place, right? And we can have common side effects as alopecia, right, our hair falling off, diarrhea, febrile neutropenia, thrombocytopenia, anemia, nausea and vomiting, which is also one of the trademarks, or myelosuppression. Now, what is the type of side effects and the metabolism of medication, right? We can eliminate them. We can work through the mechanisms of our medications through our hepatic or our renal system, maybe even both. This way, the medication per se, you would know how to target or how to alleviate the side effects mostly caused by these medications by targeting their metabolism, right? Later, I'm going to be speaking more on the toxicities of these, but I'll continue. Okay, right now, interactions and toxicity. Now, the subject of vaccination, there's no vaccination for cancer, but it is highly important to take into consideration because vaccination during chemotherapy should be avoided because the antibody response is going to be suboptimal. When chemotherapy is being planned, vaccination should precede chemotherapy by, let's say, 2 or more weeks. Patients on chemotherapy may receive the inactive seasonal influenza in between cycles of chemotherapy. The administration of live vaccinations to immunocompromised patients as cancer patients must be avoided. Live vaccines can generally be administered at least 3 months after discontinuation by chemotherapy. So I know timing and spacing may be somewhat confusing, but the importance is that when we are recommending vaccination for a cancer patient, to always take into consideration their symptoms, their treatments, and how their metabolism treatment is being handled, right? So then we have also pre-medication. Remember that the metabolisms, they might be renal, they might be hepatic. So a lot of hydration is recommended. We have pre-medication with dexamethasone. We have antiemetic medications, right? We also mentioned that one of the side effects was nausea and vomiting. So we have different categories within this anti-cancer treatments that are mild, moderate, or high-risk emetic treatments. So accordingly, you will have treatments to pre-medicate your patient before every cycle of their chemotherapy. And here you can see that our process diagram amplifies a bit more, right? For the toxicities, we have diarrhea, but yet we can also have constipation. We can have serostemia, right, our mouth dried up. We can have hemorrhagic cystitis, we have neuropathy, we can have cardiopathy, nephrotoxicity, and hepatotoxicity. So there you can see that both systems of metabolism can incur in toxicities, right? We have nephrotoxicity, we have hepatotoxicity, then we have pulmonary toxicity, myelosuppression. But once again, the vomiting and nausea. We have the mucositis. Okay, and let me go on to the next one. Okay, so before I touch up on this on chemotherapy and adjunctive medications, so toxicities, right? Toxicities can be because maybe that liver, maybe that kidney is going to overdrive and cannot metabolize the same amount of medications that we are putting into our body, right? And this is going into general. This can be chemotherapy as well as any other type of medication, right? So, but into anti-cancer treatments, there are certain medications such as bleomycin, doxorubicin, cisplatin, vincristine, that they have dosing considerations as maximum doses, and they may be a lifetime, that in a lifetime you can give this exact amount. For example, we have bleomycin and doxorubicin. They have lifetime cumulative doses to prevent both pulmonary toxicity and cardiotoxicity. We also have cisplatin that you will have a maximum dose per cycle. This is to avoid nephrotoxicity. But then we also have vincristine that it's a single dose capped, right, to a 2 milligrams to avoid neuropathy. So what I also said about the metabolisms, right? So we have to hydrate. If we hydrate, we reduce the toxicity, right? And for example, the cisplatin induces nephrotoxicity. Sorry about that, it's a tongue twister. So in addition to giving the protective, and this is the adjunctive medications I'm going to touch on right now, well, hydration is really important. I would have to say that I consider water to be the most worldwide known medication ever. Dehydration takes a toll on the human body. Dehydration will take a toll on a sick body even more. So it's very important to maintain a healthy and hydration routine, right, throughout our daily. So let's cut a bit short on our sugar beverages, right, or caffeine beverages, and just get that water, keep it going. So I'm gonna go right now here. Let me move this over here. Okay. So also, if you can help them, maybe due to copyright reasons, right, I didn't include it in my presentation, but you can look for it. It's called like the Chemo Man, and in a Chemo Man, it's more of an image where, right, we have our head, our body, our torso, everything, and the chemotherapy or anti-cancer medications, they are targeted into the toxicities that they drive more. For example, bleomycin, busulfan, carmustine, lomustine, they're pulmonary fibrosis, right? That's their toxicity. We have methotrexate, that's more for mucositis. We have cisplatin, carboplatin, nephrotoxicity, and sure, this is an overview presentation of what are the repercussions or the side effects of an anti-cancer treatment. But it's very important to take into consideration there are a lot of variables into choosing the correct anti-cancer treatment. For example, there are some medications that can be cell-specific or non-cell-specific to treat this type of cancer. So that's one of the most important factors I would have to say onto choosing the anti-cancer treatment for your patient. Okay, chemotherapy adjunctive medication. Adjunctive medications, what does that mean? Well, if you look into different sources of definitions, adjunctive means add on. You want to add on to the original treatment that's being categorized as anti-cancer and also help the treatment, right? We want to enhance the efficacy, but also we want to prevent complications. We want to avoid extravasation. These medications mostly have extravasations. Let me see if I can find it over here. We also have the prevention for the acute diarrhea, right? Because more than the constipation, they do include more of the diarrhea spectrum of it. We have to avoid nephrotoxicity, cardiomyopathy, hemorrhagic cystitis, decreased myelosuppression. And some examples of these medications, of adjunctive medications, would be Ethiol, Syncar, Todex, Fusilev, Vistogard, Mesnex. Mesnex is for the prevention of hemorrhagic cystitis. We have also atropine or loperamide, right? And you would have to say loperamide, but that's so basic. Well, yeah, because we want to treat, right, delayed diarrhea or acute diarrhea. And we have, once again, the Fusilev repeatedly with Voraxone. And these are medications that will define the efficacy of your treatment. That is why it's very important to have a complete image of how the patient is doing, right? Not only the spectrum of what their cancer is and how it's ramificated, but also what their organs entitled into the treatment metabolism entitles, right? So let's continue here. Okay. Here. Okay, firstly, I would like for you guys to notice the lower right part that says slide credit. This slide was not created by me. It is available free of charge on clinicaloptions.com. There, I would have to say, a fabulous source of information right now, and you can find any source of system in the human body that you can have information there. Also, they're very up to date with what is COVID-19. And coincidentally, while I was working, I viewed this study, this presentation that they have, and what we're seeing here is higher risk of invasive ventilation or death in Chinese patients with cancer and COVID-19. Now, the Chinese patients' reason is that, right, since this is where COVID-19. Okay, so continuing over here, the reason for Chinese patients is because since they have more time of having patients, well, it's more researchable, their type of study, right, in the population. And they were able to publish this study in February, midst of it. And what it says is that in comparison, obviously with patients without comorbidity, that it was 1.4, the crude fatality rate confirmed the percentage of it. Cancer had 7.6. That is not really that far from chronic respiratory diseases. So the incidence of these patients acquiring the COVID-19 and their death rate, well, it was pretty up high there. And also we can see here in the risk of invasive ventilation how the red line, we can see that those are the patients with cancer. And here what the probability percentage is also pretty high. Yet, when we go into the treatment aspect of it, let me change over here, there is no evidence of increased mortality from COVID-19 with recent CC or anti-cancer treatment. And the reason that this study is so important is that I wouldn't know in Bengaluru, India, but at least our CDC recommendations here in the United States and Puerto Rico, which is a U.S. territory, was risk versus benefit. So many of the cancer patient patients were not receiving their treatments, their infusions. So because they thought they were going to be more immunocompromised, the myelosuppression risk of it, the complications of it, per se, anti-cancer treatments and chemotherapy, they entitled a risk to and a stress upon the patient's body, but they didn't want to make that as a petri dish or something, as an area of opportunity for COVID-19. But with this study, we can see that if the patient is in the anti-cancer treatment, there's no evidence of increased mortality from COVID-19 in recent CT. Okay, over here, let me see. So I think I went through this very fast. I know it's a lot of information and unfortunately not as specific as I would have loved to give it, right, because of the timing. But I would have to say these are, oh my gosh, let me see over here, my references, and that will be all for me. I will be taking questions.
So now I request all the participants, if you have any questions, you can comment or you can raise your hand or you can simply unmute and talk.
I do hope that for those who know more about the subject, that it was a refresher for them. For those who are aspiring pharmacists and are actually currently participating in their ongoing pharmacy doctorate, I hope this was enlightening for you guys.
Yeah, we got one question.
Okay, is it over here?
Yeah, she says how one can detect cancer in early stages.
Okay, for my listeners here in my link, the question is, how can you detect that you have cancer? Well, cancer, it will depend on what tissue is in the body. For example, if it's in your breast, right, it's very important to have breast cancer awareness, to know how to palpate yourself, to let your gynecologist know, and also, right, there are certain guidelines that one has to follow into, if you're 30 years old but you have family history, then it's time for you to go undergo your mammograph. If you are 40 and above, then it is time on it. Likewise for the males, so prostate cancer, you have to routinely go. I would have to say that the biggest challenge on detecting cancer is routine visits for your physician or your testing routines, right? Because most of it, maybe sometimes when we do catch it, because we are feeling ill, we are presenting some symptoms, it might be too advanced to treat. And this is where we would be viewing the control chemotherapy, right? Of shrinking the tumor. Is it operable? Is it treatable? So I would just have to say that it's a huge area. Dermatologists, they can detect melanomas from just maybe you're treating yourself with dermatitis or psoriasis, and when you go to the dermatology, they can see that you have a melasma. There are different types of maybe headaches. They can be a glioblastoma. So I would just have to say that it's very important to continue your routine visits, and that's another challenge that we're viewing in COVID-19, patients are scared to go to their physicians, right? Once again, I don't know what's the scenario in Bengaluru, India, but here at least in Puerto Rico, we are pretty strict in what are the protocols to visit our physicians. We have to do appointments. We have to wait in our cars. We cannot be waiting in the physician's office or another way. We also have telemedicine, right? But telemedicine, well, the physician is not really viewing you, but rather than hearing you. So that would be more in the latest post of just communicating your symptoms. So I would say that following safety protocols, wearing your mask, washing your hands, you should be able to feel confident of visiting your physician for your routine testing.
Yes. Thank you so much. We have got one more question from Tanya Tanas. She's asking, how can we monitor the drug therapy for cancer based on the criticality of the patient? Are there any specific anti-cancer agents for various stages of how critical the patient's condition is?
Okay, so the question is, if we have a critical stage patient, how do we monitor and how do we know what medication to use in what stage? Well, that's, okay. So there are categories, there are what we call therapeutic class medications. There are many mechanisms of action. There are these type of variables that is very important, right? In what we are studying, that is pharmacotherapy or reduction in pharmacy. That is why it's not only important to know the brand name, the generic name, and just the indication, right? We need to focus on the mechanism of action. Very important, we need to focus on their hallmark side effects, right? If we have a patient that is with renal failure, we are not going to choose an anti-cancer treatment that is being metabolized by the kidney because it's already in overload, it's already not functioning, it's in a high percent potential. So we will view other types of therapy. So I would have to say that I love viewing it because I consider it to be mostly like a puzzle, right? It's a mystery. You need to first identify the stage, you need to identify if the patient is, as the person who makes the question, in a critical state. What makes the patient to be in a critical state? Is it organ damage? Is it comorbidities? Are they treated? Or despite them being treated, still uncontrolled? There are various factors that we need to draw how the patient is right there. And then on top of that, then we use there are other guidelines also. There are nccn.org. Those are the cancer oncology guidelines. And the amount of step therapies that you will find with options to treat different types of cancer is overwhelming, but that is enlightening because it gives this critical patient different options that maybe they might given up, but there are other options. I'm gonna try and take a question here from my chat. Let me see. Okay, I have a question from Amber Quiñones. It's how can we orient the community about cancer screening? I know before COVID there was a lot of health fairs, but okay, so I think I already answered this one, that we can educate our population, our community, just by being more outspoken. And I don't know if Amber is a pharmacy student or is a pharmacist, but Amber, I would have to say that we should be responsible, right, with our social media platforms, but if under evidence-based, right, we can communicate to and that's the thing, that's the beauty, what I would have to say about social media, that you're not addressing just those that you would like to be addressed, but unconsciously you're addressing your friends, you're addressing your family, to that it's okay. Like we can have measures, we can have safety measures that we can visit our physicians, that we should be routinely. And unfortunately, the incidences of chronic conditions, they're increasing. They're not being, you can see the tendencies of prescriptions going down just because the patients, they're afraid. They're afraid, and it's understandable. But us as healthcare providers, although at least in the U.S. we're not recognized as such, but we are, we should educate our community that their health comes first, and there are security measures, safety measures that can make this possible. Okay. So
I
do you have
one
another
more question from my
Okay.
side. Yeah. So basically she's asking, why is alopecia, that is the hair loss, the main effect of cancer therapy?
Oh, this is a good one. So the question was, for those who are in the different link, was that why is it that alopecia is one of the top hallmark side effects for chemotherapy? I would have to say from my knowledge, right? I'm not a specialist, but what I've learned is that chemotherapy takes a lot in what is the vasoconstriction, vasodilation of your blood vessels, right? And the heat that it transmits, well, our hair follicles, it affects a lot the extravasation. Remember what I was saying? Medications that have high extravasation, medications, even if you don't have that much of the extravasation factor in the medication side effects, just the vasoconstrictions, the vasodilatations, your follicles depend on the circulation, right? So unfortunately, that's one of the highest reasons, right? It's systematic, the chemotherapy that you're undergoing.
Yes.
So I have a question here. Can cancer be hereditary? So cancer factors can be hereditary, and that's how I just mentioned a short time ago that if you're 30 years or older, female, or even male, and have had someone first line family with breast cancer, you should have your sonogram, your mammogram being tested, just because our genetic mapping, we might have variances in our proteins or biomarkers that might incite what would be the creation of the proliferation of cancer cells. So the answer would be yes, but no, not necessarily, because my mom or my dad, God bless them, had cancer. I'm gonna have. So you should be tested. So yeah.
Yes, we have a question from Dr. Aditya. He recently completed his PharmD.
Hello there.
Hello, Aditya.
Thanks a lot, Kamran. Hi, Faria.
Hi.
My question is, is personalized medicine helpful in cancer patients?
If what?
Personalized medicine and precision medicine.
So could you enlighten what is exactly the personalized medicine?
As in the pharmacogenetics.
Gene therapy, yes. Yes, actually, okay, yes. That is, the question over here was if biogenetic medicine is as effective as chemotherapy or anti-cancer treatment. Well, actually, pharmacogenetic gene therapy would fall into an anti-cancer treatment because that's what I said, that it includes them all. The thing with genetic therapy, gene therapy, it's very expensive. And it is probable some of them are being approved with a curative indication, but like everything, it's not 100% guaranteed. And obviously with this medication, they're very specific candidates. You would have to have a genetic mapping. You would have to have proof that the mutations that you are having are in such and such protein or such and such antibody, and to treat them. But yes, there are various pharmacy manufacturing companies that have in their pipeline what is gene therapy, that is what is being viewed as the new and the top line treatments for all of these chronic and cancer conditions. So pharmacogenetics, if you have that class in your curriculum, it is going to be tough, but I have to say that I consider it to be worth it. Just make sure that you have a very comfortable semester to take this course.
Yes.
Thank you.
So we have
Goodbye.
one more question. We have question from Dhanya Naik and Afzal Khan. They have a similar question. They are asking, how do we get to know the interactions between anti-cancer drugs, and how do we alter the anti-cancer therapy in case if patients are having any organ dysfunction?
The first question is, how do we find drug interactions with anti-cancer treatment?
Yes.
I would have to say that that would be a pretty easy answer, maybe not as executions-wise, but there are a lot of databases that you just input the clinical interactions and you can review the type of interactions that they will have, right? But then again, then the other one would be, given the toxicities, the interactions, how do you manage the modifications, right? That was the other question. So physicians that are prescribing these medications, they're specialists, right? They're oncologists. They've been years in the treatment. View what is risk versus benefit for the patient. And we have to, that's it. I would have to say it's continuous monitoring. These patients, they're not the type of, okay, well, I'll see you in 6 months appointment. No, these patients, they need to be monitored very, very closely. And I would have to say that that's how you can address what are the toxicities, the interactions, and those modifications that they entitle. Yes.
Okay. First of all, thank you so much for taking out your valuable time and giving your valuable time the anti-cancer therapy. It was really very useful. I really appreciate it. And I would like to thank you once again from participant side.